training takes a long time to get to the point I'm at. So I was in school for a long, long time. I think, and in my early parts of training, I don't think I was introduced to rheumatology very well. I'm not sure I could have defined this field particularly well, like at the end of medical school, but I was very lucky to find some great mentors during my residency training that were rheumatologists, and really, I found it was the right home for me. Along the way, the other field I had been considering was hematology, actually, and I think that's kind of how I ended up triangulating on antiphospholipid syndrome as the most important thing that I study as a researcher. So I trained with both an MD and a PhD, so the idea was that I would always pursue some type of laboratory research, and I think, I just feel really lucky to have kind of found a niche where I'm able to see patients with antiphospholipid syndrome, that we also call APS, in the clinic, and then, we're able to take their blood back to the research lab and, try to go deeper into this disease and find smarter ways to treat it. So I feel very gratified to have found, like I said, kind of that niche for myself. I mean, the origins of APS, the reason that rheumatologists, have really been involved since the beginning is because they were the ones that kind of first put this whole pattern together. And that was, back in the 70s and 80s, where it was recognized that in a subgroup of lupus patients, there seemed to be the second important diagnosis that, predicted their risk of having some different types of things happen than we may commonly associate with lupus. And so we nowadays know that, APS can happen, without having a background diagnosis of lupus. And that's maybe the most common situation, actually. But, I think its origins, are always going to be kind of intertwined with lupus. We do see APS diagnosed in combination with other autoimmune diseases, sometimes rheumatoid arthritis or scleroderma. But really that link with lupus seems to be a special one that we kind of understand, but not totally. In terms of, when to think about APS, and, that goes back to the beginnings of the story, they especially recognized the risk for two things. One was we call thrombosis or blood clots. So if lupus patients got blood clots, there was a good chance that they also had this second diagnosis of APS. And the other, very unfortunate one is pregnancy losses. So, we know in lupus, like pregnancy, there's challenges kind of in its own right, but when you combine that with APS, the risks get higher. So, it was that recognition that there's a subgroup of lupus patients that seem to especially have high risk of blood clots and pregnancy problems, and it was from that the APS that we know today kind of grew out of. The thing that is most on our mind is that, I guess kind of the one-liner would be that this is it's clearly an autoimmune disease, but it's one that we primarily treat with blood-thinning medications. So, this is not very satisfying, I think, to either doctor or patient. It just feels like we're not treating things, at the source, but kind of the very downstream part of it. And so I think there's a real opportunity to kind of understand, what's underlying in the origins of APS better, that will hopefully, let us make a lot smarter treatments, treat things at the source, so that we don't have to, because, we sometimes have the conversation that based on what we know now, we sometimes talk about like blood thinners for life. And, this is a diagnosis that's often made in very young people. People of all ages, but having that conversation with like a 20-year-old person is a really tough one. And so I do think we're going to be able to do better, but it's going to kind of take 1 year at a time. We have to keep improving our understanding. we're interested in a few things. I think what we're most known for is we've been studying a type of white blood cell called the neutrophil. So this is one of several. So white blood cells are the immune cells that are in our circulation, and there's different types of them. And this is one that when I started working in this area 10 years ago that had been mostly ignored, but I think we've now shown it's an important part of the puzzle. And so, and like I said before, I think it was upstream of the blood clotting event. So I think it's another opportunity to think about a target that would not be as crude as a blood thinner, but would be somewhat more specific. I think, the thing we see in APS, probably anyone you talk to about any different condition, the same thing comes up in rheumatology. Like we use this word heterogeneity, which just means that, on the one hand, when we teach a condition to the medical students, we kind of try to make it seem cohesive so they can understand the patterns and learn about it. But then once you're in the clinic, you just see how each person living with this kind of differs from the next. And so I think we also try to keep that in mind. Like any more targeted therapy we come up with, I think, is only going to be appropriate for a subgroup of people. So it may be that we're going to need 5 different approaches. And so, that's another important aspect of our research that we can't do without, the direct patient partners. And that's, just trying to understand what makes each person different from the next and getting smarter about grouping them as it relates to potential therapeutic options. So. Yeah, anything we do would not be possible without them. If we go back to what we were doing in the very beginning, just one thing we know about APS is that the antibodies in the blood are not just kind of markers of the disease, but are actually a big driver of the problem. So one thing we can do is purify those antibodies out of the blood, and that's a really important tool to study things kind of in the test tube. But then at the same time, there's been such a proliferation of new technologies that we can use to really look at the individual cell level in the person. And so right now in our research program, we have a couple things we're doing. One is drawing blood. So I guess my patients are very generous that they're almost always willing to give us some extra tubes of blood to take to the research lab. But then we're getting into some things that are a little more invasive. And one is that we have started actually biopsying the skin, which might be a little counterintuitive, but this is a very accessible organ. Sometimes we say the skin is the largest organ in the body, and there's all kinds of tiny blood vessels flowing through the skin. And so we've kind of made the prediction that any abnormalities we see in those skin blood vessels may also be happening in the deeper tissues that are not so easy to biopsy, like the kidneys or the brain. And so we think this is, we'll see, time will tell, but we think it may be a kind of a clever way to start our investigations. And that's where just new technologies, I think the work we're doing now could not have been possible 10 and 20 years ago, because we have the ability to go into the skin, but then look at each individual cell and what its genetics are and what types of proteins it's expressing. And I think it's going to be a really important tool. But that's a place that, again, that's not something I can just conjure. We need those partners that are willing to work with us. And we've just been really lucky to have a lot of great ones here at Michigan, and people that travel from other places in the U.S. to see us here. So we're very indebted to everything they do. Yeah, I think you could say blood thinners are really the only just clearly proven treatment. Now, blood thinners is not a single drug. That's kind of a class of different drugs, right? And so I mean, yeah, I was trying to give the enthusiasm that eventually, that at least for a subgroup of people, I think we'll be able to find smarter ways, but there may always be some people that need blood thinners. But even under that umbrella, which blood thinner is the right one for which person? We probably don't want to spend time going so deep into it, but there's some newer classes of blood thinners that we sometimes use this term DUAC, or direct oral anticoagulants. And these are drugs that have, in some trials, shown some potential problems, that they don't work as well as some of the time-tested blood thinners, such as the most common one people have heard of is called warfarin. So I think, even under the blood thinner umbrella, I think there's an opportunity to get smarter about, knowing which one is the right choice for which person. I think new drugs I hope to see more of is drugs that work more directly on the immune system. So there's a lupus drug that most people have heard of called hydroxychloroquine. I predict that drug is going to have a role in some people with APS, and it is a drug that we sometimes use, although I hope the evidence gets stronger and stronger for that over time. And then I think there's potentially more potent drugs that could be a little more of a hard reset on the system. And we have a clinical trial that we just opened here at Michigan, and there's going to be other sites around the US with a drug called daratumumab, which is getting to be an older cancer drug that we think might be repurposed for a subgroup of people with APS. And so I think that's the thing to keep an eye on, is these immune system drugs. Like, let us see more and more clinical trials. And I think an important aspect is to make sure we're doing clinical trials that do not just have high level outcomes like blood clotting events, but that we're, similar to what we do in our day-to-day work in the research lab, that we're, taking blood samples and really trying to understand, how these things are working at the cell level. And I think that's the type of information that will help us predict which subgroup of patients in the future is really going to benefit from them. So it's an exciting time. Like, this trial is being supported through the NIH, which there hasn't been a long track record of trials for APS. And so I'm pretty proud to play a role in bringing this to fruition. And I just hope each year we hear about more trials for APS, which is, it's lagged behind some of the other diseases you've heard of, like lupus or rheumatoid arthritis. Well, I mean, initially I got interested in it, from a single patient I saw in the clinic, and that's often how it goes, where you just see the information I could read in the textbook was insufficient for me to make the decisions I needed for that particular patient, a patient who was around my age, and maybe that's why it kind of hit home even a little more at that time during my training. But now, I guess now that I'm into it, I just see all of the unmet needs, which is really, so you mentioned like kind of being on the front lines of treating patients and also researching them. I mean, it's great, but I also feel some amount of pressure, because every time I'm in the clinic, there's questions that I don't have the answers to. And so I think, now that I'm in this deep, it's just really, really motivating to want to do better. Like, when I have my own health problems, I want someone out there working as hard as they can to do better for me. And I think I feel an obligation now that I'm in this deep, to try to do that for people living with APS. So I cannot turn away now. There's just too much to do. I mean, I think one point to just make is that, I kind of led by talking about blood clots and pregnancy problems, and those were the patterns that kind of brought this to attention. But I do think there's other aspects of APS that, we're getting smarter about disseminating, like things like low platelets in the blood, heart valve problems. And I think these are going to get a a very good thing that's happening in the field is that there's new research criteria that will be published soon that I played actually a very small role in, but I'm very impressed with all the work that went into that effort. But I think there's still room for improvement, but it's gonna do a better job of kind of showing more holistically what someone living with APS may need to deal with. And it's just gonna, I think, be good for shining a light for doctors that are not in this every day, because we need kind of doctors out in the community to understand these patterns well enough to kind of think about the diagnosis and maybe get the ball rolling. Basically anyone I see in my clinic, someone else has had the idea and helped get them there. So yeah, I think just one aspect is getting a more holistic view of APS out there into the world. And then yeah, I think I would just circle back to that point that I think here at Michigan, there's other places around the US and really around the world that are engaged in APS research. And I think it is an understudied area. And so I think patients themselves do have a real opportunity to partner with us to do a better job. And so, people can just keep their eyes out for opportunities. It's just we need to do better, and I think it's only by working with patients directly that we're going to be able to do that. So I guess I would just say again, thank you to everyone that has helped us in the past, and anyone who might do so in the future, I thank you in advance.